Good evening. It's a pleasure to be with all of you, at least virtually. I've been asked to provide an update in the management of hyperthyroidism. Here are my disclosures. And what I want to do today is to walk through kind of our three traditional treatments for hyperthyroidism: anti-thyroid drugs, radioactive iodine, surgery, and then review some newer data about how to sort of select initial therapy among our choices. So to start with, we've had these three therapies for decades. They've been, all of them, available since the 1940s. But how we use them and what we know about risks and benefits has been evolving over time. To start with, anti-thyroid drug therapy, methimazole or PTU, these are effective for both toxic nodules, for Graves' disease. Methimazole is the first-line therapy of the two outside the setting of early gestation due to side effect profiles, which we'll talk about. It is recommended that starting doses for medications be effectively based on the degree of hyperthyroidism. It's also recommended in current guidelines, for reasons I'll discuss in a moment, that it's a good idea to get a baseline complete blood cell count and liver function panel before initiating either of the anti-thyroid drugs. Now, these are effective, both effective generally in almost all patients for normalizing thyroid function. In terms of Graves' disease patients in whom we're hoping to induce remission rates with anti-thyroid drug use are about 30 to 50% if there's treatment for 12 to 18 months. But if at that time point the TSH receptor stimulating antibody is still positive, those remission rates are much lower. They're less than 20%, and in some studies they really approach zero. In individuals with Graves' disease who are treated with anti-thyroid drug and then that anti-thyroid drug is stopped, the recurrence rate is going to be highest in the first 6 months after stopping the anti-thyroid drug. And it's reasonable, if the Graves' disease remits and recurs, to think about treating with definitive therapy, but it is not wrong to reinstitute anti-thyroid drug and to continue it for the long term. Adverse effects of the anti-thyroid drugs occur in about 13% of patients overall. Most frequently, that just manifests as a rash. It occurs in 3 to 6% of individuals. In most patients, rash can be managed with antihistamines, but there are some desensitization protocols that have been described in the literature. So working with an allergist, it is possible in some of these patients with allergies to desensitize them and allow them to use the anti-thyroid drug meds. Agranulocytosis is a feared consequence of both methimazole and PT use, but it is rare. It occurs in 2 to 5 individuals per 1,000 patients treated, with the highest risk being in the first 90 days after starting or restarting therapy. Hepatotoxicity is also feared. It is more frequent with PTU than with methimazole. So it occurs in about 2.5% of patients treated with PTU, 0.4% of those treated with methimazole. What we fear the most, of course, is those rare cases of fulminant hepatic failure that have been described specifically with PTU. And as for risk for agranulocytosis, risk for liver injury is highest in the first 90 days after starting the drug. ANCA-associated vasculitis can occur with either of these medications, but it is rare, and it is more frequent with PTU than with methimazole. Pancreatitis is newly added to package labels in some parts of the world. I'll discuss that in a moment, but that risk seems to be associated specifically with methimazole, and that absolute risk is quite low, less than 0.4%. And then finally, both of these medications are teratogenic. But the birth defects associated with methimazole are both more frequent and more severe than those associated with PTU, which is why in early gestation, PTU is the preferred drug. Now, in treating patients with Graves' disease, often with anti-thyroid drug, we are hoping that they will ultimately go into remission. And there are some predictors that can help us, determine the likelihood that this will happen. So people less likely to go into remission of their Graves' disease with anti-thyroid drug are those who are younger, those who are male, smokers, people where this was diagnosed in the postpartum setting. Larger goiter is a risk factor. There are some genetic predispositions. And then finally, worse Graves' disease, and manifested either as particularly high TSH receptor antibody titers or extrathyroidal involvement with eye disease are predictors of less likely remission. Now, in patients who do not remit, where we elect to continue treatment for the very long term, this is the study I know of to date that has had the longest term follow-up. So these are data from Faridun Azizi's group in Iran. This is a fairly small cohort, 59 patients with Graves' disease, all of whom had been on methimazole for 14 years already at baseline in this study. And then about half of them opted to discontinue the methimazole and half of them were opted to continue on it. These were patients on pretty low dose, an average of 2.5 milligrams a day. None of them had adverse reactions over this very long follow-up period of an additional 6 years after the initial 14. But again, the study is small enough, you might not expect to see those rare side effects. Important to note that of the individuals who discontinued methimazole after 14 years of treatment, most remained euthyroid, but 20% developed recurrent hyperthyroidism. So it's not totally clear. There are some patients who really may never be able to stop. With regard to concern about liver toxicity, this, I think, is a very useful study to know about. These are data from a meta-analysis published in Thyroid in 2021. And what these authors did was look at liver function tests in individuals with hyperthyroidism, mostly Graves, but also toxic nodules, both before and after initiation of antithyroid drugs. And what they found is that the majority of hyperthyroid patients actually will have at least one liver function test abnormality at baseline, presumably due to the hyperthyroidism itself. After initiating antithyroid drug, as thyroid function improves, these liver function tests typically improve too. And this is true even when the baseline transaminases are 5-fold above upper limit of normal. So it is not a contraindication to treatment with antithyroid drugs in these patients, but it is probably a good idea to get your baseline liver function panel, just so you know if questions arise down the road, whether the liver function test abnormalities are related to antithyroid drug use or to the underlying hyperthyroidism itself. The same group published a very similar meta-analysis looking at baseline white blood cell counts. And what they found is that before initiation of antithyroid drug, having hyperthyroidism was associated with mild, usually not clinically significant, neutropenia in about 10% of patients. And again, mostly this improves as the hyperthyroidism resolves. So probably a good idea, again, as current guidelines suggest, to get the CBC before initiation of treatment, just again, so that if any questions arise down the road, you know what might be due to antithyroid drug and what was present at baseline. The pancreatitis risk is not something I had thought about at all until recent years, but in 2019, the European Medicine Agency added acute pancreatitis to the list of adverse effects specifically of methimazole. That was based on what at the time was just 6 case reports, although there are now further reports in the literature. This has not been added to packaging in the US or in other regions as far as I'm aware. I think if this is a true association, the absolute risk is quite low, but it's probably reasonable to let patients know to be alert for symptoms. Now, radioactive iodine, again, been around since the 1940s. This is not a new treatment modality, and it's quite effective. It will cure hyperthyroidism in more than 90% of patients, really, across multiple studies. In older individuals, those with cardiovascular risk, it is probably important to beta block before radioactive iodine treatment and to consider pretreatment with methimazole, although that pretreatment may decrease the efficacy of the radioactive iodine therapy. This is contraindicated in pregnancy and lactation. It may worsen thyroid eye disease, so it's really contraindicated in severe or active Graves' ophthalmopathy. It requires safety protocols around radiation exposure. And the goal in Graves' disease is to really ablate the thyroid. So the expectation for a patient with Graves is that they will, 100% need lifelong thyroid hormone replacement. For autonomously functioning nodules, the best number I can find is about a 60% requirement for ultimately needing thyroid hormone replacement. After treatment, thyroid function needs to be monitored fairly closely. I'll show you some new data for that. And also there are new concerns in recent years about the potential for inducing solid tumor risk for the very long term. Now, which of those patients that we treat are those who are likely to have a treatment failure, about 10% in most studies? The radioactive iodine will not work, or at least not on the first attempt. Here's a recent meta-analysis looking at risk factors for treatment failure, and some of them overlap with the risk factors for not having remission in Graves' disease with antithyroid drugs. So these risk factors include male sex, large goiter, worse hyperthyroidism at baseline manifested by higher free T4 levels, but also high radioactive iodine uptake signals less likelihood of effective therapy, delay of treatment for after 6 months following Graves' disease diagnosis does as well, and a history of antithyroid drug therapy. So pretreatment, again, may decrease the likelihood of efficacy. Now, these are data that I think are important. They suggest that as providers, we are not doing a very good job. This is a cohort study that followed 812 patients for 12 months after their initial radioactive iodine treatment for hyperthyroidism and just looked at likelihood of thyroid dysfunction over the ensuing year. And what they found was that only 9% remained consistently euthyroid following their radioactive iodine treatment. Over 80% were hypothyroid for some of that period, almost half were hyperthyroid for some period. So this suggests to me that probably we need to be following thyroid function more closely and intervening more quickly when thyroid dysfunction occurs or recurs following radioactive iodine. With regard to risk for solid tumor risk and solid tumor mortality, this was kind of a blockbuster study published by Kari Kitahara in JAMA Internal Medicine in 2019. So her group looked at a cohort of about 19,000 patients from the US and UK who had been treated with radioactive iodine for hyperthyroidism starting sometime between 1946 and 1964, and then had very long-term follow-up. Most, but not all of these patients were treated for Graves' disease. And what they saw was that for every 1,000 patients treated with kind of typical radioactive iodine doses for hyperthyroidism, there was an excess lifetime risk of 19 to 32 solid cancer deaths. Now, that was criticized in part because they didn't look at risk with the other treatment modalities. So that was followed up by this analysis of the same cohort a year later, where they compared these risks in patients treated with radioactive iodine versus antithyroid drugs or surgery or a combination. And what they found here with a mean follow-up of 26 years was no difference in solid cancer mortality across these three treatment modalities. But for the studies that looked at it, for the patients where they had looked at dose response, there was a dose response relationship such that higher administered radioactive iodine activities were associated with higher risk for solid cancer, especially for breast cancer in women. A meta-analysis then combined data from 12 studies to examine this question. This included almost 500,000 participants, and what they saw in this analysis was no increase in cancer incidence, no increase in cancer mortality with the radioactive iodine treatment, and no significant risk for specific types of cancers, with the exception of thyroid cancer, which makes sense because that's the organ that's going to have the most direct radiation exposure. However, again, in the two of the studies in this group that looked for it, they did see this dose-response relationship, higher doses associated with higher risk for breast cancer and solid cancer mortality. So I think the bottom line from what we know to date is that there probably is a real risk, but the absolute risk is very small. So I think this is worth discussing with patients, but you don't want to scare them away from an effective therapy for a risk that in fact is really quite low. Finally, thyroid surgery has been around, for a long time. It is highly and rapidly effective for curing hyperthyroidism. It will decrease symptoms from compression from goiter. This is particularly beneficial in patients with thyroid eye disease, as it may improve their TED. And it's indicated, of course, if there is known or suspected thyroid malignancy. Risks are primarily risks to the recurrent laryngeal nerve, or the risk of inducing permanent hypoparathyroidism. And for this reason, selecting a high volume experienced thyroid surgeon is extremely important because those risks are much higher in the hands of non-experienced surgeons. In patients with Graves' disease, they will unequivocally need lifelong thyroid hormone therapy. In patients following lobectomy, the majority of patients will not. But total thyroidectomy is the treatment of choice for Graves' disease. Lobectomy would only be appropriate for, toxic nodules. So then we have these three major treatment modalities. How do we decide between them for initial treatment choice? So part of that is informed by the underlying etiology, remembering, of course, that toxic nodules do not go into remission. We need to think about patient-specific factors, age, comorbidities, the severity of the hyperthyroidism, the likelihood of eventual remission if it's Graves' disease, any plans for pregnancy, availability of skilled surgeons, and then, of course, patient preference. And these decisions really do need to be patient-centered. What are we doing for treatment? Well, in the US, we have this study published in 2020 that looked at data from 2005 to 2013 in a national US sample. And at that time, 60% of patients with Graves' disease were being treated initially with antithyroid drug, 33%, a third, being treated initially with radioactive iodine, which is higher than in most parts of the world, although represents a decline in previous practices in the US, and then a minority, only 6%, initially opted for thyroidectomy. They then looked at the likelihood of treatment failure for each of these modalities, and defining that was fairly straightforward for surgery or for radioactive iodine. For patients getting antithyroid drug, treatment failure was defined as somebody who's treated with antithyroid drug for at least 60 days and then either stops and has to restart after at least 3 months, or needs radioactive iodine or surgery following the initial period of antithyroid drugs. The treatment failure rate was 50% for antithyroid drug, but importantly, it dropped to 25% if there was treatment of the hyperthyroidism for at least a year with medication. Failure rate for radioactive iodine was 7%, and it was effectively 0 for surgery. Notably, the median time to treatment failure in the antithyroid drug-treated patients was only 7 months, suggesting, again, the duration of therapy was probably too short. 12% of patients had side effects with antithyroid drugs, 6% with radioactive iodine, and 24% with surgery, probably reflecting too many low-volume surgeons in the mix. A similar study was done in Hong Kong recently. Here, the vast majority of patients got antithyroid drug, and the relapse rates reported here after therapy, 2% for surgery, probably reflecting not total thyroidectomies for Graves, whopping almost 76% for antithyroid drug, and about 10% for radioactive iodine. In that analysis, they looked at the likelihood of long-term development of both mortality and cardiovascular disease by the initial therapy that was selected. The antithyroid drug in the blue line, those patients fared worse, and the surgery patients in green fared best. They looked at long-term costs, and over 10 years, this was published by surgeons, keep in mind, but they found surgery to be the most cost-effective option. Now, a similar analysis, network meta-analysis published in 2022, looked at cardiovascular effects with long-term follow-up after each of these three hyperthyroidism treatment modalities, and found that congestive heart failure, arrhythmia, atrial fibrillation, hypertension, all were lower in patients treated with surgery compared to those who got either antithyroid drug or radioactive iodine. And we most recently, my group has looked at the same question really in a national Taiwanese database, concluded effectively the same thing, that compared to individuals treated for Graves' disease with antithyroid drug, surgery was associated with lower long-term risk for cardiovascular outcomes and all-cause mortality. Radioactive iodine compared to the thyroid drugs was associated with lower cardiovascular risk. And I think all of three studies probably are related to the fact that we are controlling hyperthyroidism faster with surgery than with these other modalities. But I think if we monitor more carefully and are more aggressive about maintaining euthyroidism, the other treatment arms are probably equally or at least nearly as safe. Internationally, what are people choosing for treatments right now? These are data from a very recently published survey that looked at surveyed endocrinologists from 85 countries. They had 252 respondents. They looked at treatments for Graves' disease with sort of an index case. So it was kind of your average case, and then they varied it a little bit. What you see across the board around the world is that blue, which is antithyroid drug, is the preferred modality, no matter the treatment, no matter kind of the patient characteristics, but that there's more likelihood to choose radioactive iodine in older patients, those with long-term persistent disease, or those with Graves' disease relapse. more tendency to opt for surgery in patients with thyroid eye disease or those who are planning pregnancy. So I conclude by noting that we always need to establish the etiology before starting treatment because there are risks and benefits of all three treatment approaches. Decision-making needs to be shared with patients. We need to consider individualized factors, and there are some new treatments in the pipeline that will be coming. With that, I thank you for your attention.